Hi, everyone. I'm Dr. Ernest Joseph Barthelemy. I'm currently the chief resident in neurosurgery at the Mount Sinai Health System in New York City in the USA. And I'm also a former Paul Farmer Global Surgery Research Fellow at Harvard University's program in Global Surgery and Social Change, as well as a proud member of the World Federation of Neurosurgical Societies Young Neurosurgeons Forum. And it gives me great pleasure to participate in this transformative conference organized by the Young African Neurosurgeons Forum, as well as other friends and colleagues who brought us together around this incredibly important topic, traumatic brain injury on the African continent. And I also feel honored to follow my mentor, Dr. Key Park, in this segment on policy, advocacy, and governance, and the role that these activities and approaches has to play in improving care for traumatic brain injury in low and middle income countries. So if you are viewing this video, it's because I am unfortunately tied up with clinical duties and unable to attend live. And so I will go ahead and share my screen now to present some work that we did at the program in Global Surgery and Social Change on this topic. And this will be on the topic of neurotrauma surveillance in low and middle income countries. And we will review some of the results of a review we did of data dictionaries of the national trauma registries of several of these nations. I have no disclosures for this talk. And in the way of background, Dr. Park may already have introduced the volume that we published in 2019 on comprehensive policy recommendations for head and spine injury care in low and middle income countries, which was published by the Global Neurosurgery Initiative of the program in Global Surgery and Social Change. And many of the relevant findings that were reported in that volume include that the global burden of neurosurgical diseases is estimated at least approximately 22.6 million, with 13.8 million of these cases, or 61%, requiring operative neurosurgical intervention. The vast majority of these cases, unsurprisingly, occur in low and middle income countries. And this overwhelming burden of disease stresses the importance of developing strong surveillance methods for global neurotrauma so we can start to improve on the data available on this disease entity in low and middle income countries, and come up with constructive ways to strengthen our healthcare systems so that we can better address this burden of disease. And so there are approximately 6 million traumatic brain injury related deaths annually, with nearly 70 million newly diagnosed cases each year. And so the importance of this public health crisis cannot be overstated, even as we deal with other public health crises. And so the objectives of this work really looked at the first component of a 5-component framework that was utilized in developing the policy recommendations that we mentioned earlier. Surveillance, prevention, pre-hospital care, the surgical system, and rehabilitation were the 5 components. And this study focused on the surveillance aspect. We performed a literature review aiming to identify and analyze the national trauma registries of low to middle income countries with an eye towards appreciating the neurotrauma specific data dictionaries utilized in those registries. And then there were a number of non-randomized sampling methods that we used to supplement the literature review, again, aiming to find contextually relevant data from low and middle income countries that other low and middle income countries might learn from in shaping and ultimately strengthening their health systems. So again, the goal was to use the data collected and to actually inform the way in which that data is collected so that we might ultimately strengthen future surveillance efforts using data from countries that can be benchmarked um, versus other countries. And so not to fall into some of the external invalidity that we run the risk of falling into when we try to borrow methods from high-income countries and impose them on contexts that work in a quite different manner. And so just quickly, this is some of the inclusion exclusion criteria that we used for the literature review portion of this work. We tried to include as many languages as could be handled by our group. Looked at studies published after 1991 and used the World Bank's definitions for low and middle income countries. And so income definitions that were broadly applied for what constitutes an LMIC. Registries looked at in this study had to be national trauma registries, which didn't preclude them from being used at individual facilities, but they had to be based on a nationally standardized template. And the registry had to include neurologic or TBI or even traumatic spine injury specific elements. And we excluded review articles or conference abstracts or any other political barriers to calling the registries in question bona fide national trauma registries. Okay, and so here's our workflow. So starting out with 1,829 studies imported from our search query for screening, we ultimately were able to include 20 studies after moving them through the prism and criteria that I just shared. So that was the literature review component of our methods. And then, as I said earlier, we supplemented these methods with a non-randomized sampling process. And so that included direct contact of researchers from a convenience sample, cold contact of ministries of health from the 19 low and middle income countries that our team was able to identify at that time with a strong enough internet presence to gather further data, as well as direct contact of global organizations involved in advancing TBI care, organizations to which many of us belong. And so we used all of this to compile a representative sample of traumatic brain injury and traumatic spine injury as well, data dictionaries from low and middle income countries. And so the results of this work were that 20 articles from our original 1,829 met inclusion criteria, and combining the results of that review with our non-randomized methods yielded 16 active registry data dictionaries for neurotrauma surveillance from the following 14 low and middle income countries that you see here, including Cameroon, Egypt, Rwanda, and the other territories that you see listed here. Data elements for neurotrauma surveillance varied markedly among these nations, with only one nation, the nation of Cameroon, including all of the minimal data set for injury from the World Health Organization's International Registry for Trauma and Emergency Care. So after reviewing the data dictionaries from these trauma registries, we wanted to compare them with an international standard just to see how well each of the registries we found reflected the WHO's recommendations for data collection around neurotrauma. And Cameroon, again, was the only nation that had a complete agreement with the minimal data set. And 6 out of the 16 registries that we found included a majority of these MDI fields, including fields such as admission vitals, the Glasgow Coma Score, mechanism of injury, a method of arrival, and discharge disposition. So this array here shows you the results of that reconciliation, the reconciliation of data dictionaries from each of the trauma registries from each of the countries in question, as they compared to the TBI-related elements of the minimal data set from the WHO. So in conclusion, we found 14 low and or middle income countries with national trauma registries that provided us with 16 registries. So several of the countries had more than one trauma registry, such as China, Iran, and Jamaica. Limitations of the study included language barriers in our ability to maximize the amount of data we could collect from various countries, the need for countries to have an internet presence to be found by our non-randomized sampling methods, and varying resources with regard to data collection and publication from country to country. Collectively, we hope that this data can be used as a template for national neurotrauma registries and surveillance systems in low and middle income countries. Everyone at this conference readily appreciates that neurotrauma is the #1 neurosurgical disease burden on the planet, and surveillance is a key component of reducing morbidity and mortality related to neurotrauma. So we hope that the findings of our study can be used as a guide for health policy officials in designing responsive and effective emergency health and trauma systems by strengthening the surveillance component of that 5-component framework. I do hope to be able to return to the conference live to address any questions. Otherwise, I can be reached at the email shown here, globalneurosurgeon@gmail.com. And my Twitter handle is also listed. Thank you for having me, and enjoy the rest of the conference.